calculated. The INR is derived from prothrombin time PT, which is calculated as a ratio of patient's PT to a control PT standardized for the potency of the thromboplastin reagent developed by the World Health Organization using the formula INR is equal to patient PT divided by control PT. All right. So basically, it's a prothrombin time, which is of the patient and the control, and you divide that and you get a ratio of it. The normal ratio is 1, but in patients who are taking warfarin, 2 to 4 or sometimes 2 to 3.5 is considered normal. So since this particular patient is taking warfarin, this ratio is normal for this patient. But if the patient wasn't taking any blood thinning agent and he wasn't on warfarin or something, then this is a high ratio, and then you would have referred this patient to a hematologist or a GP to understand why this ratio is big, because then it would increase the chances of bleeding. But patients who are taking warfarin, this is normal because they are taking a blood thinning agent. You understand? That doesn't mean their clotting factors have a problem. They are taking an anticoagulant. So you should be prepared with some hemostatic measures, but expect the clotting to happen properly because they are taking an anticoagulant. So there is no problem in their own clotting mechanisms. You understand? So here it is proceed with surgery using hemostatic measures. That should be your answer. The action of warfarin is increases the production of vitamin K in the body. What is vitamin K? With respect to the blood factors, it initiates the clotting mechanisms. If you get a cut or an injury, then that is initiated. There are two, three different mechanisms, extrinsic and intrinsic. One of them have vitamin K, and it initiates the clotting factor. So warfarin is not going to increase its activity. That means it's promoting more clotting. We don't want more clotting. Antagonistic to vitamin K in the body. That is the answer. Decreases the production of platelets. It's not antiplatelet. Warfarin is not. There are other drugs which are antiplatelet. Given in therapeutic guidelines, please go through it. Prevents platelet aggregation, increases platelet adhesion. No, it is just purely antagonistic to vitamin K, which determines prothromboplastin activity, and hence that test has to be conducted. The patient is not happy to do a blood test and insists that her GP told her she can have any dental treatment. What do you have to do? Never believe the patient, ever, ever, ever in your life. Understand what the patient is saying, but always make your own decision because it's you who are going to do the treatment. The patient can always go back verbally, oh, I never said that type of thing. So always you have to document things properly, take signature consent. So whenever patient says, oh no, my doctor has said, what if she is lying just to go through the procedure early as possible because she is in a hurry? So never believe the patient. Even if the patient says so, ki, doctor, why don't you just do it? I spoke to my doctor. Fair enough. But since I'm your doctor, I need to just double uh, be concerned about your own safety. And that is why let me speak to your GP, or you can get a clearance through your GP. So listen to the patient desire and commence the treatment now. You are a doctor. You are not some carpenter or plumber that whenever the person is saying something, you just go ahead and do it. No offense to them. I'm just telling you that it's not something that you just fix it. You are treating a human being basically. Trust your patient's words and commence the treatment. No, never trust patient. Dismiss the patient and insist on necessity of INR test before the procedure. You can be insistent on INR test. But what if the patient has just got the INR test done from the GP and she doesn't want to take it due to any phobias and whatever? So if you have that report ready from the GP and the GP gives you a clearance, then you can go ahead with the procedure, right? Contact her GP before commencing the treatment. That's true. That should be the case. You necessarily, I mean, it's a very good idea to have the report in your own hand. But suppose the patient yesterday night only got the blood test done, and you speak to the GP and the GP says go ahead, then you can. Then you just ask the GP to fax you or email you the report, have it in your records, and just go ahead with the procedure. So I hope this is clear. You will definitely get medically compromised cases in your exam, both in ADC Part 1, both in ADC Part 2, and in your life. You have to be prepared for it. And the more you read, the more confident you will feel to practice. So I hope this is clear and helps for all the new candidates. I have given a sample of mock test in the description. You can just go ahead, click on the link, solve it to get a taste of ADC exam. And we have a Facebook group, Target ADC. You can just join that. You'll in the file section, you'll get all the books out there. So if you want to study by yourself, go ahead. Just trying to make it as reachable to all the students as possible with minimum involvement of me. Because I do keep on getting lots of emails and messages. Just where are the books? And I keep on saying every time it's on Target ADC Facebook group. Just go get it, guys. I don't have to email it to you all. But for the mocks, yes, you'll have to email me because mocks are something which are very hard earned prepared that I cannot share just like that. So, but yeah, I am doing my bit in solving one question a day at least. So yeah, about that. Hope all of you are doing fine. I think a month, no, it's September exam, right? So just about a month and a half for the exam. Solve mocks, revise, revise, revise. That's the key. Focus on your preparation. Don't worry about the result. Result will come whatever it has to. You just focus on your work. And if there is any doubts, need motivation, anything, just drop it in a comment. Bye bye.